Great. So Ali kind of gave some background here, just a little bit of kind of additional background. So Lashika and I, both have interests in OB, of course, while we're here with you this year. And as part of kind of our fellowship on Thursday mornings, we've been splitting time working with the UW OB providers while their residents are in lecture. So we've had a little bit of kind of like exposure to some of this care from their lens, and knowing that there's momentum going towards our own department having permissions and active management of insulin, magnesium drips, and antihypertensives for our laboring patients with an OB consult. That's kind of why I think in combination with Ali, we're working towards creating some of these learning sessions. So just a kind of a note that these will be primarily focused on inpatient management alone. We'll really kind of get into the nitty-gritty of some of the documentation and the order sets as we go through this, but really will not be as focused on like things like screening and diagnosis, antepartum surveillance, or induction of labor timing. Those things are all kind of more leading up to the labor admission, and so will not be the focus primarily of a lot of these talks. But kind of a glimpse of the upcoming sessions and the schedule we have right now, that for January and February, Lashika and I will split just kind of talking about some background for management of gestational diabetes, as well as preeclampsia with severe features. And then in March through May, we'll talk a little bit more in depth about current hospital protocols. We'll look at actual order sets so that people are familiar with those and kind of can save them in their own favorites at Meritor, and then some documentation recommendations as well. I just kind of came up with something that's objectives. Sorry, Lash, I didn't ask you if these are okay with you, but hopefully they are. But current objectives of the sessions would be to interpret current literature within the context of society guidelines, summarize existing hospital protocols, make sure that we all can feel like we comfortably can utilize these order sets, and then can perform appropriate documentation. And today I'll really just be focusing on those first two, and the summary of existing hospital protocols will be kind of brief and more of an overview. And then I have the Meritor diabetes guidelines kind of marked up a little bit with some highlights. And so we'll be sending those out to you to review on your own prior to the next session, so that you're familiar with kind of the specific intrapartum management guidelines from Meritor's perspective. I have not gone over anything at St. Mary's, since this seems like it's primarily happening on the Meritor front right now, but certainly I'm happy to kind of take a look at that in the future should the momentum be swinging in that way at St. Mary's as well. Okay, so looking at blood sugar management in labor, current guidelines really assume a causation between maternal hyperglycemia during labor and neonatal hypoglycemia. There's actually quite mixed literature about this, and we'll go over that just to kind of make sure that we all feel like we have a similar degree of context from where these guidelines currently live in kind of the existing body of literature. Serena Schrager, Billy Michael, and I actually did a review of this for a recent evidence-based practice article. So I kind of just stole from the stuff that we did for that, just to kind of give you guys some context of the studies that we looked at. Just a note that a lot of these studies actually do not clearly delineate between pregestational and gestational diabetes. So many of them kind of lump that management when they're looking at maternal blood sugar versus neonatal outcomes. They kind of lump pregestational and gestational diabetes together in many studies. It's not always clearly delineated. There are some specific studies that look at type 1 diabetes in particular, and I guess just kind of note that we will not be focusing on type 1 diabetes because those patients should always be receiving insulin. So this is really kind of probably could be parlayed into thinking about kind of in our own practice more gestational diabetes, and for some folks if they have, depending on their level of control, type 2 diabetes as well. But let's go through some papers. So kind of looking at from 2010 onward, there's a couple that are kind of note. There was a 2013 review from these two authors that looked at 19 studies with nearly 2,000 women. Again, kind of a composite of pregestational and gestational diabetes in the studies that they looked at. 10 out of those 19 studies showed an inverse relationship between maternal blood sugar during labor and neonatal blood sugar. 3 out of 19 of those studies showed a trend toward that relationship, and then 6 out of 19 showed no relationship. The authors concluded that this supported an intrapartum blood sugar goal that was really like the blood sugar goal that they used at their own institution. And kind of, if you read the review, kind of with a critical lens, it's really not a systematic review at all. It does not have a method section. It does not do any formal quality assessment of the studies. And so it's kind of a very limited overview, but it is a review that's out there and that is cited. So important to be aware of. They kind of used their findings to support their own institution's protocol. And I would say that the existing literature, when you look at kind of smaller studies, also looks a lot at people publishing their own institution's protocol. And those can vary widely in terms of use of insulin and use of IV fluids, including dextrose-containing fluids versus something like LR or normal saline. But so when you kind of like do a deep dive into some of the smaller studies, it gets very variable very quickly. Then more recently, there was a 2017 systematic review from Yamamoto and others that looked at 23 studies with just over 2,800 women, again, with a composite of both pregestational and gestational diabetes in these studies. And both of these reviews were kind of a mix of retrospective and prospective studies. Of those 23 studies in this systematic review, 6 showed a relationship between maternal hyperglycemia and labor, and that being related to neonatal hypoglycemia. 5 out of 23 showed a relationship in some, but not in all analyses, and 12, so half the studies out of those 23 showed no statistically significant relationship between intrapartum blood sugar management and neonatal hypoglycemia. They concluded that only one of the studies was at low risk of bias, and they noted in particular that there was very inconsistent reporting and adjustment for confounders, and particularly confounders that they talked about were things like prematurity, size for gestational age, maternal factors, including maybe things like maternal BMI, maternal blood sugar control in the 3rd trimester. And they had considered doing a meta-analysis of these studies, but found that the heterogeneity of the studies limited their ability to do a meta-analysis, and so that was ultimately deferred. Kind of moving on front, when Serena, Billy, and I looked at the existing literature, we really only found one RCT that kind of looked at this particular question of maternal intrapartum blood sugars versus neonatal blood sugars. So this was a study done in 2019 that randomized 76 women with singleton pregnancies and solely looked at GDM, so no pregestational diabetes in this study. Randomized them in a 1-to-1 ratio between a tight blood sugar control group and a liberalized control group. The tight control protocol was looking at a blood sugar goal of 70 to 100 with checks every 1 hour during labor. And notably that 100 is lower than our current institution's goal blood sugar of less than 110. And then the liberalized blood sugar group, the kind of upper threshold of that did not indicate treatment was 120 milligrams per deciliter, and they ended up checking blood sugars every 4 hours as opposed to hourly. And then they looked primarily, the primary and secondary outcomes were neonatal, and it did show a trend towards lower blood sugars in general in the first 24 hours of life in the tight control group. But there was really no statistically significant difference in the kind of first measured neonatal blood sugar measurement shortly after birth. There was no difference in the incidence of hypoglycemia or the interventions for hypoglycemia, and there was no difference in the number of NICU admissions between the between the two groups. However, notably, the NICU admissions for the infants in the from mothers in the tight blood sugar control group were admitted for hypoglycemia, and the one infant that was admitted to the NICU in the liberalized control group was not admitted for hypoglycemia. And then the literature has a kind of ton of some retrospective cohort studies. So this is just one of many, but kind of the most recent one. And again, comes from Yamamoto, who was involved in the systematic review from 2017. And and I believe they're based out of Canada, and Canada seems to have a little bit of a more kind of trending towards a liberal approach to GDM management, which we'll talk about a little bit more in a second. But this was a larger retrospective cohort than I'd seen previously. This was looking at 36 almost 3,700 women, again, kind of a composite of both pre-gestational and gestational diabetes, though they did do breakdowns between type 1, type 2, and gestational diabetes. And they kind of looked at what they considered to be an in-target blood sugar from like, not in the metric system, 63 to 117 milligrams per deciliter for women in labor, and looked at the incidence of neonatal hypoglycemia, which they defined as any sort of treatment with dextrose. And they found, after adjusting for neonatal factors, including prematurity and size for gestational age, that there was no statistically significant association between in-target control and neonatal hypoglycemia. So all of this is to say kind of a little bit to kind of say that while we are kind of entering the realm of doing this care in the hospital, that we should be taking this a little bit with a grain of salt when we're thinking about starting to kind of manage IV insulin, and knowing that the literature really is not clear right now if this actually impacts neonatal outcomes in any sort of positive way or in a negative way. And many of these studies call for increased randomized trials to kind of see if we can get a better sense about whether kind of what the actual blood sugar threshold should be in labor, and whether or not blood sugar control in labor is at all related to neonatal hypoglycemia, or if in fact those are maybe related more to things that are either not related to the blood sugar control in labor at all, so things like size for gestational age, which probably reflects blood sugar control prior to the time of delivery, or things like prematurity, which may be not related or kind of just peripherally related to the diagnosis of GDM. But so just kind of trying to make sure that we all have that same kind of background and context, and are at least aware that these recommendations may change in the future, but that we should be kind of comparing this evidence or kind of aware of this evidence when we're kind of going into the realm of managing IV insulin drips on the floor.
Sally, could I ask a quick question?
Sure. Yeah.
Do they have any sort of maternal outcomes that they're evaluating, or is it really that they're looking at neonatal hypoglycemia? Like, are there any other factors that they're even trying to pay attention to?
You know what, I can
in an accusatory way, just curiosity.
Yeah. In this most recent study in particular, or
and any of them?
Yeah, I would say there is some, and that's kind of like what the systematic review and the kind of other Yamamoto systematic review talked about, is that really it's variable when they report. So we'll report on kind of some maternal factors. Some of the studies did report on like incidence of maternal hypoglycemia, because there is some concern surrounding that. Like some of the thresholds for the in-target control, like a target of 63 for a laboring patient is like, that to me is like, that's not ideal, right? For a woman who's like about to undergo a very large physical feat, having a blood sugar of 63 feels like an adverse event to me. So I would say, again, very kind of variable. But some did report on kind of the incidence of maternal hypoglycemia in particular. But again, and then kind of not all of this, I am, from my kind of memory of looking at this literature, not a lot of it kind of talked about things like, you know, incidence of, some of them did talk about like kind of method of delivery, like, you know, cesarean versus vaginal, but not all of them, I think, that I'm remembering kind of looked at things like adverse delivery outcomes or complicated deliveries, things like shoulder dystocia, et cetera. Okay, let's keep moving. So society recommendations, this is kind of what's currently out there. ACOG recommends a blood sugar goal during labor less than 110, specifically for pre-gestational diabetes, but does not make specific recommendations about gestational diabetes. Though, as we'll kind of see in practice, that seems to be kind of currently people are being managed kind of in one lump group here for the most part. And then other societies of note, the SOGC from Canada, Royal College of Obstetricians and Gynecologists from the UK, and the US Endocrine Society all recommend a blood sugar goal that's a little bit kind of with a higher threshold of 126 milligrams per deciliter. And in general, it seems from my kind of, I haven't looked at this specifically, so but just kind of anecdotally, it does seem like some of the literature surrounding maybe trending towards kind of liberalized control of blood sugar during labor comes a little bit more out of like endocrine journals here in the US, maybe more so than OB journals. That's not, that's again, kind of my just peripheral review. So I'm not sure that that actually bears out. But yeah, so then kind of we will dive in a little bit more into the current guidelines at Meritor. And again, I'll talk more about this at the next session, but this is just an overview of what it currently looks like. And I have the kind of highlighted protocols with me as well, which we can look at certainly if there's any kind of more in-depth questions. But the current guidelines at Meritor actually kind of are, they look at all of diabetes and pregnancy and kind of look at prepartum, postpartum, and intrapartum. And so kind of the areas that I've highlighted really have to do with intrapartum management. They recommend an intrapartum blood sugar goal of 70 to 110. So again, kind of fitting within that ACOG guidance of an upper threshold of 110 milligrams per deciliter. They use the word general recommendations for blood sugar checks. So the current kind of suggested timing is every 2 hours in early labor and every 1 during active labor. But then they give also a caveat that if someone is in cervical ripening phase and they're still eating, that you could follow something akin to a fasting and postprandial check schedule, similar to what they've been doing at home. Notably, kind of both of these, this blood sugar check schedule and kind of in general, they assume an NPO patient during labor for a lot of this guidance, which I know is not necessarily always the case for patients, depending on kind of their decision to pursue an epidural, depending on the concern at all about need for emergency surgery, depending on the provider comfort, which I know kind of varies between family medicine and OB as well. So just knowing that a lot of this guidance comes from assuming an NPO patient or at least a clear liquids patient. And then the recommendations mentioned to start IV insulin when the patient is in active labor and a blood sugar reaches over the threshold of 110, and then stopping that IV insulin at the time of delivery. Checks as soon as someone is on IV insulin continue every hour, and it's all a nursing-driven protocol. So much in the way if folks have managed DKA or insulin drips in any other hospital setting, this is pretty much something that the nurses see the orders and take care of, and that we would really be notified if things were kind of not going according to the protocol. There is some contingency planning for hypoglycemia, which we'll talk more about at the next session. But for the most part, I see that it kind of generally runs fairly smoothly, and more often than not, the nurses are contacting you if there's concerns about hypoglycemia more so than difficulty controlling elevated blood sugars. And then it's also kind of an insulin drip that's very easy to stop in ways that kind of maybe if someone's in DKA, there's a little bit more complexity with kind of titration of the drip and kind of transition into another form of insulin. But this is not the case for patients with gestational diabetes. So the plan is just really stopping at the time of delivery because there's no current continued indication for insulin at that time. And just kind of anecdotally, my own observations is that this is very variably practiced. And so part of this comes from kind of my observations as being a resident over the last 3 years. And then part of this also comes from seeing what the UW OBs do and seeing even kind of variations within their practice group. So knowing that kind of what the hospital protocol says is one thing, but then I would say there is still quite a bit of variation in terms of implementation on the labor floor. So I've seen many patients with A1-GDM get a blood sugar check on admission and then no further blood sugar checks. And I've seen that both in the side of family medicine as well as the side of UW-OB. I've seen that a lot more commonly from our department than from their department, though I have seen it kind of from both department providers. And then from like my perspective, looking at patients who are being started on IV insulin, this is primarily from my work kind of with the UWOB providers over the past couple of months, that often there's kind of a grace period that's given to patients to kind of see if their blood sugars normalize on their own with maybe either kind of some modification of things or just with time to like, there's kind of a little bit of a grace period given to see if they don't necessarily need the insulin drip. So I think it does seem like it is many people recognize that this is while it's just something else going through the IV and just a nursing protocol in some sense, that it also is kind of another medicalization of a patient's labor. And so I think most folks try to kind of weigh not risks versus benefits, but just kind of maybe have a little bit of a gray area or some kind of nuanced threshold perhaps to when to start insulin. So I've seen some people hold insulin drips if they realize that someone's been having like cranberry juice for hours on end. And so then they take away the cranberry juice and the blood sugars get better and then they don't have to start IV insulin. I've also seen, some folks after they get terbutaline will have some temporary hyperglycemia. So they'll allow some grace periods for that. Usually for patients who have had steroids, I've seen some folks kind of wait as well to initiate IV insulin, but theoretically, I think the thought is that, that steroid activity will be going on for some time. So the hyperglycemia is probably going to be more prolonged. And so those folks more often than not, I see get initiated on steroids. Yeah, I think those are kind of the big kind of scenarios that I was thinking about that kind of have a little bit more nuance to them. I have seen some of the OB providers also just kind of oddly at times, like if a patient is pushing and the blood sugar is like 130, giving like a couple units of Lispro. And I'm not sure that always makes sense. And that is not clearly delineated in the current hospital protocol. So it generally kind of looks like, and what we should be expecting as we kind of enter this care is that if the plan is to start insulin, we should probably just be starting with the IV insulin drip, and that if it's really nearing the time of delivery, that probably the administration of insulin may not actually impact the neonatal blood sugars actually significantly at that point. So that's kind of a summary of what I have to say today. Things that I will do in between now and the next session is send out the kind of a highlighted copy of the current Meritor guidelines, and may send out one or two of the studies that we talked about today. And then we'll be working with Ali and Lashika to see if there's any sort of like other kind of modules, or, if we should be doing any sort of case-based practice things and disseminating that as well. So I will work on that. And in the next session, what I'll plan to do is do a more in-depth review of the current Meritor guidelines. We'll kind of go through that all together, and then can look at order sets and documentation. And I would say that generally this is a lot simpler than management of severe preeclampsia in terms of magnesium and antihypertensives. So Lash definitely got the harder of the two topics. But I generally think that this is fairly straightforward. It's something that we are generally familiar with in other medical contexts. And so the management of IV insulin is something that should generally feel fairly comfortable to most of us, though we should be kind of prepared to know what the nursing protocol looks like, look at what the management of hypoglycemia, especially for mom, looks like. But I think all of that while knowing that this is still kind of a nuanced area, and that the OBs seem to, the UWOB providers seem to have some nuance to their decision making based on what I've observed. And there does seem to be some nuance in the current literature, as well as varying society recommendations. So just kind of as we enter this realm of care, just understanding all of that and balancing all of that, but probably also sticking to current hospital guidelines is the best path forward. But that is it. I am happy. I want to give a shout out to Serena and Billy Michael, who helped me, or we all worked together for this evidence-based practice review article, which was made this presentation a lot more easy to compile. And those are some of the sources. And that's it.
Alyssa, can you hear me?
Yes, I can.
I have a couple of questions or clarifications I would like for you or Ali to clarify, because you said we need to get an OB consult. So I want to know what the consult is for and what do they do. And number two, what if a patient, I don't know if we're going to start managing patients that have insulin as pregnancy, or if that is definitely a referral.
Yeah, I can speak to some of that. And Ali, if you have anything to add, let me know. I have seen, from like from the OB consult perspective, I have seen this one or two times from a family medicine patient. And from the perspective of a family medicine patient being admitted and then OB being consulted. And their consult note is usually pretty darn close to what the hospital protocol recommends. So they will just mention starting insulin at a blood sugar greater than 110. They sometimes will think a little bit more about, or kind of comment a little bit more on the potential size of the infant, and kind of if there has been a growth ultrasound or not been a growth ultrasound, perhaps comment on that, and discuss kind of, being prepared for delivery outcomes, including things like shoulder dystocia or need for a cesarean section should there be any sort of a rest. But really, from my review of those consult notes, it's really just a recommendation to follow the hospital protocol, which is to treat with IV insulin drips for a blood sugar greater than 110.
Why do we get a consult if we are going to be doing that?
Because baby steps, Patricia.
A step at a time and a little bit of formality, but to make sure everyone is on the same page also would be my guess.
So we get the consult, but basically we do kind of what the protocol says, but just so that they are happy that we talk to them.
I think in so many words, yes. I think it's a kind of a courtesy and awareness piece of things right now.
Okay, so what about patients that need insulin during pregnancy to manage their diabetes? Is that a referral to OB even before and then during labor, or not?
So I've seen, and I don't know, Ali, if you can speak to this, I've seen varying practices based on the provider's comfort level prior to delivery. And so, I know Lee, I think for some patients has kind of co-managed that with perinatology. But I have not seen that across the board for everyone, but I'm not sure if there's any kind of more specific guidance on this. Ali, if you don't have any information, let me know.
I do agree, Patricia. I think we need some clarity on that. The specific change was really in reference to inpatient meritor because it was meritor policy. And so I think that this certainly will foster support in having comfort with us being able to take over. Generally, I think as it stands for outpatient insulin management of gestational diabetes, had previously and probably still is in a refer to OB. And I know that was kind of a sticking point even a couple years ago when the gestational diabetes recommendations changed. I think kind of starting with these inpatient changes and kind of getting to that comfort will then kind of shift to kind of comfort in that being transitioned to us being able to manage insulin outpatient more comfortably as well. But we are going to sit in a little bit of some non-clarity on that probably for a little bit still.
Wanted to make sure that as a group we agree on what, because unfortunately we have different skills, and some people that has higher skills for OB might do it, but then if I'm on call and that person is not there, then I want to know what the group kind of stand on this is.
Yeah, and that is exactly what we want to kind of address by doing a little bit more in-depth of educational for this, is we really want to get our residency faculty and community faculty who participate in these, like I said, we'll be able to have these online, be able to feel comfortable and educated and know the evidence, know the protocols, know the nitty-gritty details of being able to do this, so that there isn't quite as much kind of fluctuation, at least across some of these, what we deem as kind of core OB topics for training of our residents. So we will work on making sure we're consistent across that. But this is part of that effort.
Hey, Allie, this is a little bit like outside of the scope of this lecture, but the other thing that I have noticed is that the outpatient counseling for pregnant patients with diabetes is all totally siloed with April Eddy, and it would be really great if we could have somebody within our department who was, I actually don't even know if there's like a certification process or whatever, but it would be really great to have somebody that we could refer to that that was just kind of like under our auspices rather than under MFM's auspices.
Definitely, yeah.
This is Angela. I just want to say that at Access, we have certified diabetes educators and nutritionists who are managing our A1 GDM patients. And if the department gets a referral within, I don't think we can accept not Access patients, but I'm sure our team would be willing to work with whoever to kind of build a program. They've been awesome.
It's interesting, at Belleville, we have a new diabetes nurse educator, and we've talked with her about this. And so it sounds like I have a name from that faculty meeting, like who the next person up is on the chain, because she has gotten explicit instructions that she is not to work with patients with gestational diabetes. So as with many things in our organization, I think there's probably some unnecessary turf wars that are trickling down.
Excellent.
The other person, this is Strietler, the other person that we could tap into if people are interested is Denise, one of the certified midwives. Her PhD work was in gestational diabetes, and she's very interested in caring for these patients. But again, like Jency said, there might be a little bit of a turf war, but she's also a resource that I've turned to.